cholangiocarcinoma. So, as you probably know from this junior case from this morning, this tumor arises from the bile duct epithelium. It accounts for 5 to 30% of primary malignant hepatic tumors, and they are the second most common cancer in the liver. The incidences of malignancy are increasing, and usually these tumors are poor prognosis. You have two classifications for this tumor. The first one is a classification according to the location of the lesion. So there is 3 types of cholangiocarcinoma. The first one is peripheral or intrahepatic cholangiocarcinoma, is around 10 to 25% of the lesion. The second type of lesion is hilar cholangiocarcinoma, which represents around 50 to 60% of cholangiocarcinoma. And the third type is cholangiocarcinoma, which is a distal extrahepatic cholangiocarcinoma, and these types of cholangiocarcinoma represent around 20 to 30% of all cholangiocarcinomas. You can see here the location. But there is also another classification which is based on pathologic reports, and that concerns the morphologic aspect of the tumor. So you may have a nodular or mass-forming type, around 20% of the cholangiocarcinoma. The most important type is the periductal infiltrative tumor, like here, is more than 70% of the case. And you may have very seldom an NTRADUCTAL growing tumor, which represents around 10% of the case. We're going first to see the peripheral cholangiocarcinoma, which is a mass-forming intrahepatic cholangiocarcinoma. And that is the most common type of intrahepatic cholangiocarcinoma. At close pathologic examination, peripheral cholangiocarcinoma typically manifests itself as a large, white tumor with dense fibrosis. And peripheral cholangiocarcinoma are usually large because they are rarely symptomatic early in their course. So when you will do ultrasonography, you can detect the tumor and get a first impression about resectability. But ultrasonography is unable to characterize the lesion because there is no specific sonography feature. You may have a hypoechoic lesion like here, hyperechoic lesion, or a mixed echogenicity lesion. So you really need to do a CT or MRI. A CT is a preferred method for detection and characterization, and I will show you some examples, but you will see irregular mass, lobulated, with minimal peripheral rim, enhancement during the arterial and/or portal venous phase. You may have a focal dilatation of intrahepatic ducts around the tumor, and, which is very important, usually there is a prolonged enhancement at the delay phase. And sometimes you may have a capsular retraction. More or less, if you do CT or MRI, you will have the same features of the tumor. What about the distant staging? Usually it's done by CT, but you can do a PET CT for that also. So the typical pattern of peripheral cholangiocarcinoma is like that. You have an enhancement here, a re-enhancement of your lesion on arterial phase, and after on portal venous phase and on delayed phase, you have a progressive filling and a late central enhancement. You may have associated abnormalities like here, intrahepatic bile duct in around 20 to 30% of the case, and a capsular retraction that you can see here in around 20% of the cases. Now, if you move to the typical pattern of MRI, the lesion is usually hypo to hyperintense on T1 weighted imaging, and on T2 weighted imaging, the hyperintensity of the signal depends on the amount of mucinous material, fibrous tissue, and tumor necrosis. On enhancement, T1 weighted imaging, you will have the same feature that on CT, and you can see here a re-enhancement of arterial phase, and on portal phase and delay phase, a delayed progressive enhancement here on this delayed phase. Be careful, you can have some pitfalls. The first one concerns patients with liver cirrhosis. You have to keep in mind that cholangiocarcinoma may arrive in such patients, but when you look at the lesion, you will have a late enhancement because of the fibrosis component of the lesion. So there is no washout. And that can really help you to differentiate a cholangiocarcinoma from an HCC. And in patients with cirrhosis, you may have also a capsular retraction. So if you look, for example, this patient, you see this is a liver cirrhosis. You see here the lesion, and after an arterial phase, this here the lesion, and you have this re-enhancement of the portal phase and a progressive enhancement on delete phase. That doesn't look like at all as an HCC lesion, but it's typically a cholangiocarcinoma on liver cirrhosis. And this patient has a second lesion that you can see here, with enhancement of arterial phase and of portal phase and delete phase, no washout. Because we're thinking that probably this patient doesn't have an HCC but a cholangiocarcinoma, we do an MRI. And on MRI, it was exactly the same aspect that on CT. You see this lesion here on arterial phase, it's on completely enhancement lesions. You see on portal phase and here on delayed phase that there is enhancement of the lesion because of the fibrosis component of the lesion. And the second lesion has exactly the same aspect here that the previous lesions. So we conclude that this patient doesn't have an HCC. We do a biopsy, and the biopsy concludes that it was a cholangiocarcinoma. The second pitfall concerns the adenocarcinoma metastasis, because sometimes that can be exactly the same aspect. But you have the chance to have a patient's medical history, which can indicate susceptibility for that. And if you really don't know, you have to biopsy the lesion and go to pathology to do an immunophenotyping of the lesion. And if there is a cytokeratin 7 positive, that indicates that it is an intrahepatic cholangiocarcinoma. But in the case where there is a cytokeratin 7 negative, that indicates that this lesion is a colorectal liver metastasis. Here is a TNM classification of intrahepatic cholangiocarcinoma. I think what we have to remember probably is the prognostic factor. The first one, which is very clearly demonstrated in this nice paper, that it depends on the enhancement of your lesion. There is two groups of patients. One is a typical group, like here, there is a rim enhancement on the arterial phase, and another group of patients can show enhancement on the arterial phase, a more higher enhancement on the arterial phase. And if we compare these two groups of patients, these authors show that you have really a better prognosis if you have this atypical enhancement on arterial phase than if you have a typical enhancement in terms of overall survival and in terms of disease-free survival rate. The other prognostic factor that everybody knows are the tumor size, when the tumor size is more than 2 centimeters or 3 centimeters, when there are multiple tumor or intrahepatic metastases, vascular invasion, lymph node metastases, peritoneal carcinomatosis, and extrahepatic metastases. All are very poor prognostic factors, and there is probably no benefit to surgery in this patient, and it's very easy to see. Here, for example, you have satellite nodule on MRI. Here you can see a vascular invasion on this huge cholangiocarcinoma lesion. Here, lymph node metastasis, one here, another one here, and here an example of a peritoneal carcinomatosis. Now we move to the second type of cholangiocarcinoma, which is the hilar cholangiocarcinoma. This lesion is an infiltrative peri-hilar lesion, and with a very poor prognosis because the 5-year survival toll is around 20 to 40% after surgical resection. Which is very important to understand is that this tumor has a multidirectional mode of spread, and the longitudinal spread is probably very important for year 0 resection. And that is the most important prognostic factor. Here is it illustrated here. You have this submucosal spread, which has been evaluated around 10 millimeters after the tumor. So when you do ultrasonography, usually you can detect the bile duct dilatation of the tumor in patients with jaundice, because this technique is inexpensive and widely available, but you don't really see the tumor. The tumor can only be shown in 37 other cases. So you will need to additional imaging for deeper evaluation. So the diagnosis and preoperative imaging is based on FDCT with NPR and MRI with MRCP. The accuracy of resectivity for CT has been evaluated around 16 to 87%, with the negative predictive values around 85 to 100%. And really, you have a huge benefits of using thin slices for advanced post-processing data. I will show you some examples if you want to do multiplanar reconstruction, maximum intensity projection, or minimum intensity projection. And in addition to the MDCT, you have to do an MRCP for the bile duct involvement, and the accuracy of bile duct involvement using this technique is around 18 to 96%. And the aim of this imaging is to fully assess the extent of the disease and its resectability. So, I show you two examples of imaging presentation of cholangiocarcinoma. This one is a periductal infiltrative type. You can see here a stop of the signal and the dilatation of the intrahepatic bile duct. Here you see hyperenhancement on arterial phase or your lesion of the cholangiocarcinoma, and here you see the hyperenhancement of the portal venous space. That is one aspect of the imaging presentation. The other aspect is a mixed pattern, when you have a mass forming and a periductal infiltrating pattern. Like that, you have this infiltrating pattern, and in addition, a mass forming on the confluence, at the level of the confluence of the bile duct. So you have 5 questions to answer for the radiologist. The first one is, what is the longitudinal extent within the biliary tree? Second question, is there vascular invasion? Third question, is there hepatic lobar atrophy? Do you see any lymph node metastasis? And finally, do you see any elongated metastasis? We will start with the first question. Evaluation of longitudinal extent. That means that you are going to evaluate the first and second confluence of bile duct. You can do CT with MPR at initial diagnosis test, and the accuracy for that is less than 60 to 70%. Usually, underestimation are more common than overestimation. Why? Because the cause of underestimation, and because you don't see this subepithelial spread of diffuse infiltrative type, and because you don't see really anatomic variation. And the causes of underestimation are cholangitis and drainage catheter. I show you one example. So, look at this patient. There is bile duct dilatation. You very nicely see here this little tumor, cholangiocarcinoma. If you want to answer the question for the longitudinal extension of bile duct, you do NPR and you do minimum projection, as you can see here. You see the bile duct dilatation. There you see here the left hepatic bile duct, here the right hepatic bile duct. There is no dissociation between the anterior and posterior bile duct. And here you see the structure of the left hepatic duct, and here on the right hepatic duct. So you can conclude that probably, in this case, it's a cholangiocarcinoma type 2. But of course, it's better to use MRI with MRCP, because that your accuracy is better. It's around 18 to 96%, and it has been proved to be better for predicting ductal involvement than CT. And even some tip use this MRI with MRCP as one-step imaging modality. And again, it's more common to have underestimation than overestimation. So, when you have an MRCP, we use this dismute coordinate classification to help the surgeon in determining the types of surgery. There is no information regarding vascular engagement, local or distant metastatic spread, lymph node metastasis, and hepatic lobar atrophy. And this classification is not indicative of resectability and survival. So there is 4 types of bile duct involvements. The first one is type 1, where you can see here on MRCP and here the comparison on ERCP. You can see here the bile duct dilatation, and here there is no signal because of the tumor. You see here the structure of the common bile duct, and here you have the cartoon of this tumor invasion. So here is the type 1 of bismuth coordinate classification. The type 2, you have here an MRCP type 2 and the correlation with PTC type 2, and here the cartoon. You can see that there is bile duct dilatation, no dissociation between left hepatic bile duct and right hepatic bile duct. You don't have signal here at the upper of the common bile duct, and you can see very nicely the structure here because of the tumor. More complicated is probably after what is exactly a type 3. I show you here a type 3 left. Here you have the cartoon. We show you the invasion of the tumor in the left hepatic duct. And here you can see on this MRCP the bile duct dilatation, here the left hepatic duct, and inside the left hepatic duct you can see here the tumor in this image and also in this image here. There is no, the common bile duct here is okay, and there is no dilatation of the right hepatic duct. And finally, if it's a very huge tumor, you can have a type 4. And here's an example of the type 4 on MRI. You have here the cartoon, where you see the invasion of the left hepatic duct and right hepatic duct. And you can see very nicely here the dissociation between the anterior and posterior bile duct, and here segment 2 and segment 3. And there is an invasion of right hepatic duct, left hepatic duct, and the upper of the common bile duct. What is very tricky is to pay attention of bile duct variation, because sometimes that may contraindicate or not the surgery. For example, in this patient, you see there is bile duct, a diffuse bile duct dilatation, and it was, you can see here the lesion on T2, weighted imaging here and here. And we was thinking that maybe we can just remove one left or right liver, and because it was a type, probably more a type 3A in this patient, but because of the trifurcation of the bile duct that you can clearly see here, you see the posterior hepatic bile duct is different from the anterior hepatic bile duct. Because of this anatomic variation, it was contraindicated for surgery and go to a liver transplantation in a special program after radiotherapy. I'll show you another example, very common example, where you see very nicely in this woman of 61-year-old on MRCP that this right posterior bile duct go into the left hepatic bile duct here, you see that? And here on MRI, you have bile duct dilatation. You can see here the very small cholangiocarcinoma, here on portal vein enhancement, here, the small tumor. And this patient go to surgery, and she had a left hepatectomy plus segment 1 and a double biliary anterior reconstruction here on the posterior and anterior bile duct. So be careful of the bile duct anatomic variation that can really change the type of your patient. Just to remember that when you do MRCP, is more or less the same result that NTC, and echocardiography proved to be almost as efficient as ERCP or PTC for the depiction of biliary extension, and the correlation between both techniques are very good, around 88%. So, with the video, but anyway, so you have exactly the same image here on PTC and using 3D MRCP. Now it's okay. It's working, so you see here very nicely the same here, the same structure. So the second question was, is there vascular extension? That is very important too for surgery. So to answer to this question, probably CT has the advantage of higher resolution in comparison to MRI. I show you this example. You see here a woman of 65-year-old. You see this cholangiocarcinoma here on arterial phase. This is a lesion here on portal phase. And the question is, where of the surgeon is, where is the hepatic artery, and is there enhancement of portal venous vein? And you can see very nicely here, after mid-reconstruction, that the artery seems to be very nice, with no enhancement, and that was the same for the portal vein. So this woman go to surgery, and she had the left hepatectomy plus segment 1. And exactly like for the Viaduct anatomic variation, MDCT is very nice to show you hepatic anatomic arterial variation. Here, for example, in this patient, you see this bile dilatation on the left liver and right liver. You see very nicely this lesion here on arterial phase and here on portal phase. But what can you see in addition? You see here that here there is a left hepatic artery. You do your reconstruction, and you can see that the surgeon probably is going to do a right hepatectomy, but he can keep the left liver because of this anatomic arterial variation, because of the presence of a left hepatic artery for the left liver. So you prepare your patient, of course, because the liver, the left lobe here is small. You do a right portal vein embolization. This lobe is going to grow, and after you can do the right hepatectomy and treat the patient. So the MCT is used also for the estimation of the lobar atrophy. So before doing this kind of surgery with portal vein embolization, you always have to have an idea of the volume of your liver. And there is special software for that, and that gives the surgery, for example, to show it between a left hepatectomy of a right hepatectomy. Now we move to the question of the lymph node. I think it's a very difficult question. MRI and CT have similar and suboptimal accuracy for the depiction of lymph node. So you can see the lymph node, but it's almost impossible to tell with 100% of, to be sure to be 100% that is metastatic lymph node or is just inflammatory lymph node. I just want to show you this case. You see this patient, bile duct dilatation, you see very nicely the tumor here. Of course, we said in the radiology report that there is a lymph node here and another lymph node here. But because they were small in size, we are no doubt. We think that this patient can go to surgery. But it was not resectable because this lymph node, after picking on operative surgery, was a metastasis 1. So it's very difficult to tell, okay, don't operate this patient because this lymph node is a metastatic 1. So we have a big problem with that, and the PET-CT doesn't really resolve this problem. So you have to mention it, but I don't think you can really tell, at least it is a very big one, it's a metastatic lymph node for sure. What about distant staging? It's a rare condition at initial staging. CT usually is a preferred method, although early peritoneal carcinomatosis may be overlooked. And There is no recommendation for the use of PET-CT at this stage, except probably in patients with sclerosing cholangitis, where PET may improve the detection of cholangiocarcinoma according to this order, but I'm not really sure, it's still controversial. Because the reported results from a few PET investigations are variable. You may have false positive FDG uptake in inflammatory lesion, false negative result in mucin producing tumor. So really the role of PET-CT in future investigation in this kind of tumor. Very quickly, a short word of what is exactly an extrahepatic cholangiocarcinoma. The third type of cholangiocarcinoma is more or less the same that hilar cholangiocarcinoma. You may see a wall thickening of the extrahepatic duct or a mass at the porta hepatis or in the periocular region, and proximal biliary dilatation. I show you here example of this CT. Bile duct dilatation, you see here a wall thickening of the bile duct, here on the axial view and here on the coronal view. And here on MRI, you see this wall thickening on T218 imaging on MRI and the correspondence image on ERCP. Just the TNM, one word. Remember that there is one TNM classification for hilar cholangiocarcinoma, which is staged as it was in TT, and another TNM classification for extrahepatic distal cholangiocarcinoma. They are not the same. I will just turn my talk for this last new classification of biliary neoplasia that we call NTRADUCTAL biliary neoplasia, which are very rare, and that include the old NTRADUCTAL cholangiocarcinoma, in addition to papilloma or papillomatosis, what we call now NTRADUCTAL papillary neoplasm of bile duct. And they include also the cystic cholangiocarcinoma, where we can see a huge mucin production. The location of this NTRADUCTAL biliary neoplasia may be peri-hilar, intra or extrahepatic, and the prognosis is, of course, much better if surgery is feasible. The diagnosis of this tumor may be challenging because you may have a diffuse form or a lobar dilatation of the intrahepatic bile duct, and this lobar dilatation is marked if there is a mucin production. And you can see that with or without an NTRADUCTAL soft tissue polypoid mass, obliterating the lumen. And when you see this mass, usually there is a very relatively weak enhancement of arterial phase or portal phase, and maybe sometimes you can have just a wall thickening. And because of this mucin production and the localized form, you can see a lower atrophic hypertrophy complex. Let me show you one example. For example, in this patient, man of 49-year-old, you have this cystic lesion. There is a cystic lesion on ultrasonography. You can see this lesion here on T218 imaging, on axial T218 imaging, and you see here that there is a communication of this lesion with the bile duct. Here you have the MRCP, so here you have the lesion, and here the bile duct communication and bile duct dilatation. And there is no dilatation on the left liver. Here is the MRI on T1. You see that this lesion is high presence on T1 within imaging. Maybe that you can see a weak enhancement of the peripheral of the lesion here, and again, you see dilatation of the bile duct and communication of the bile duct with this lesion. And here, after surgery, is the pathologic specimen, and you can very nicely see here that it was an NTRADUCTAL papillary neoplasm of bile duct with mucin production. So, in conclusion, imaging manifestations of cholangiocarcinoma are extremely diverse. Since these tumors vary largely in growth pattern and location, and you will need to do accurate detection, characterization, and assessment of the resectivity of the tumor on the primary goals of imaging. And you have to do both. CT and MRI are still improving day after day and are complementary. Thank you.